Hello. Today I am going to be discussing the shared decision making processes and recommendations that occur for people who have amyotrophic lateral sclerosis, specifically who have ALS and dysphagia symptoms. First, let's begin with an overview of everything I'll be discussing today. We'll begin with a topic introduction as well as background information of key terms addressed throughout this study. We'll then take a look at what current day measures look like and end with the research aims and questions that are driving this study. The research topic that I'm studying is the understanding of shared decision making used by healthcare professionals surrounding diet texture modifications in people with amyotrophic lateral sclerosis. This research will be conducted as a qualitative review of participants through the use of interviews and questionnaires. I'd like to begin by briefly reviewing some of the disorders or conditions mentioned that are key elements within this study. To begin, what is ALS? Amyotrophic lateral sclerosis is a nervous system disease that affects both the upper and lower motor neurons. ALS causes a loss of muscle control, and the disease gets progressively worse over time. ALS often brings with muscle twitching and weakness in arms or legs, trouble swallowing or slurred speech, and eventually ALS can affect control of the muscles needed to move, speak, eat, and breathe. The exact cause of ALS is still unknown, and only a small number of these cases have found to be inherited. There is still no cure for this fatal disease. Here's a further breakdown view of these symptoms, specifically noting differences between the symptoms observed from upper motor neuron changes or changes in the brain versus lower motor neuron changes or changes in the spinal cord. Although it is hard to be sure due to the CDC not requiring healthcare professionals to report records on ALS, it was still estimated by the CDC that every year about 5,000 people are told by their doctor that they have the disease. Next, what is dysphagia? Dysphagia is defined as difficulty or inability to swallow and is a symptom that occurs in many different medical conditions. These conditions include nervous system and brain disorders, muscle disorders, and physical blockages in your throat. Now, why is it important that dysphagia is understood in this study? Well, that's because an estimated 85% of individuals with ALS will experience dysphagia at some point during their disease. And this is when the healthcare providers typically recommend a diet texture modification. So, what is a diet texture modification? This chart is used by the International Dysphagia Diet Standardization Initiative, and it ensures consistent and safe recommendations across all patients once recommended a diet texture modification. Diet texture modification will include changing the viscosity of liquids and/or softening, chopping, or pureeing solid foods using standardized guidelines. When considering recommendations for a diet texture modification, there is no shared decision-making process, and it is so important for healthcare providers to do their due diligence to consider the patient's entire framework, their personal, environmental, or behavioral factors, for example, that may also be affected by such a drastic change. Other options for treatment do exist. However, this is one of the most commonly recommended treatment for ALS patients experiencing dysphagia, as it is more to decrease safety concerns. Providers are well aware that these patients' swallowing condition will continue to progressively decline, and swallowing could become more of a prevalent safety concern, which is why so many providers use this as a recommended treatment. Here we can see more specific data on how many ALS patients were recommended a diet texture modification in 2012. In 2012, it was stated that the use of modified diets to try to prevent aspiration and its consequences in those with dysphagia has increased dramatically in recent decades. Thickened fluids are used in up to a quarter of long-term care residents, 15 to 30% of long-term care residents, and 30 to 45% of older people in acute and rehabilitation wards receive modified texture food. Unfortunately, there's limited research done on ALS and diet texture modifications, so this is the most relevant and recent article I could find. However, it is assumed that these numbers have only increased over time. Now, we've talked a little bit about this shared decision making process. Now, what do I mean exactly by that? I mean a shared decision that is made between the patient and the healthcare provider. However, also one that emphasizes the need for a shared decision making process between the different types of healthcare providers that are making these recommendations. As you can see, occupational therapists, nurse practitioners, speech therapists, physicians, and dietitians are all able to make these recommendations of a diet texture modification, making it increasingly important to create some sort of shared decision making model for all of these healthcare professionals. When these providers are considering recommending a diet texture modification, what are they actually considering? Diet texture modifications are difficult to recommend and to analyze overall results of, as each case is so unique and situation dependent. For example, if an individual with ALS who is having trouble eating anything at all throughout the day and receiving hardly any nutritional value, adjusting food texture and liquid consistency while still prioritizing nutritional quality could be crucial in managing dysphagia to help this sort of patient to meet their nutritional needs. This can also reduce choking risks and aspiration risks for this type of patient, as well as possibly improve quality of life, as this patient is now able to eat independently throughout the day and potentially reduce their fear of choking while eating as well. On the other hand, if an individual with ALS is still able to eat some regular and soft and bite sized pieces of food, and that is something that they enjoy, then they might fall on the other end of the spectrum where potential harmful side effects are observed. This individual may experience a reduced appetite, as thickeners can provide a feeling of fullness, which can make it hard to get in enough nutrition. Or they may miss the mealtime satisfaction, causing them to eat less. As you can see in this picture above, to put it bluntly, diet texture modifications do not always look the most appetizing, and this could then affect their quality of life, creating social isolation, which could affect the patient's overall adherence to the treatment as well. There's also a lack of evidence to make firm conclusions if a diet texture modification is a promising strategy for improving nutrition. There is lack of shared language and decision-making processes used by healthcare professionals, which could also be harmful as patients may not be informed of all of their options. As mentioned previously, this could be due to healthcare providers opting for the safest choice rather than observing the patient holistically. As previously stated, the current decision-making process surrounding diet texture modifications is currently quite varied amongst healthcare professionals. Right now, this process looks like recommending treatment based on evaluation, having a discussion to determine best options with the patient, determining level of food that the patient will be at based upon the IDDSI framework we viewed earlier, and then conduct ongoing evaluations to possibly make modifications to their diet. As you can see, there's currently not a lot of structure to this process right now. There's also no ASHA policy or guidance directing the use of diet texture modifications in dysphagia management. ASHA has stated that SLPs are simply encouraged to explore the current evidence and consider patients holistically when developing individualized plans of care to meet those patients' individual needs. An issue that we see arise here is there's not enough evidence to consider for these SLPs. This space that is then left for providers recommending treatments when no parameters and guidelines are in place becomes a potential harm for these patients to receive appropriate care. And this is where the aims for this research majorly drive from. After hearing all about the background information and what is being addressed within this study, what are the research aims? As stated previously, there's no ASHA policy or guidance directing the use of textured modified diets in dysphagia management, and there's currently very little research being done for ALS patients specifically surrounding the effectiveness of diet texture modifications. Variation in the decision-making processes and language used by differing healthcare providers regarding diet texture modifications is also potentially harmful for individuals with motor neuron disease. The hope within this research is to create a more structured decision-making process that can be shared within an interdisciplinary approach, as well as share more knowledge surrounding ALS and dysphagia to provide a better experience for those individuals and to ensure that they are part of the decision-making process as well. My final question for this research is, how do patients feel when recommended a texture-modified diet, and do they feel the decision was a shared decision? Going off of that, when considering a diet texture modification, do ALS patients feel that the language used by their healthcare provider during the decision-making process affected their perception of their outcomes? Here's my works cited, and thank you for listening.